we are ready with the live case. I would request all the panelists one by one to please come forward. And for this, I would request Dr. Atul Mathur,
Ujjwal,
Dr. S.M. Sharma,
Ujjwal, run
Dr.
the
Kapil
video.
Bhargava, Dr. R.R. Mantri, Dr. Sanjeev Roy, Dr. G.L. Sharma, Dr. Jitendra Makkar, Dr. Sarita Chaudhary,
Ujjwal,
and also this case would be moderated by Dr. George and Dr. Roxana. So I
Ujjwal,
request
run the video to
chairpersons
save the
and
time.
moderators to please take it forward from here. Thank you.
All right, we're all set here in the auditorium, and hello, Dr. Sharma and team from Eternal Heart Cardiac Catheterization Laboratory. We can see you very clearly, and good morning from the conference center.
Yeah, and good morning, and you can hear us also because we can hear you very well now.
Yeah.
Yeah, very, very well. You can
Beautiful.
increase a little bit volume, increase a little bit volume from Dr. Sharma's microphones,
All right.
but we're very clear.
Okay.
Go ahead.
So key is that myself, Dr. Sanjeev Sharma, of course, and rest of our cath lab team from EHCC, welcome and ready to show this live case. And we try to show something different. I know a lot of discussion on the calcific, bifurcation, and left main. And what about if I say everything is in this case? And not only the what type of atherectomy to do and so. So with that note, we show our small video. I don't know if they have played it. If not, we are ready to show our slides.
Video was shown already.
What the video was shown earlier.
Okay.
Go
Very
ahead.
good.
Go ahead.
Okay.
We can move on to the case presentation. This
Next.
is a complex PCI under imaging guidance, calcified left main bifurcation. Next one, please. This case is a 71 years old female who has been hypertensive hypothyroidism for last 4 to 5 years and having underlying CKD. Creatinine is around 1.5 and EGFR is 37 millimeter per minute. And she presented to us with a history of progressive exertional chest discomfort and dyspnea, NYHA class 2 to 3, and recent in onset for last 2 weeks. ECG shows left bundle branch block, and echo showed EF of 50% with septum paradoxical. So LV is well preserved, no significant mitral regurgitation. Next one, please. Now we can clearly see the diagnostic angiography. Left main is tapering down in the distal segment, and that is encroaching upon the LAD and circumflex ostium. And circumflex is continuing as a large OM, and that is 90 to 95% long segment disease, right from proximal to mid segment. And go to the next view, please. The LO caudal view, we can clearly appreciate there is a distal left main tight stenosis and reaching to the ostium of LAD and the circumflex.
71.
And RCA has a moderate disease, the 40 to 50%. So it's a typical left main bifurcation, Medina 111, a fibrocalcific lesion, and we did the imaging for that. Next one, please. So plan is to do a IVUS guided PCI for left main bifurcation, which has been discussed in the last session in very much detail. And definitely the imaging remains class 1 indication in such a kind of a case. And we have planned for doing it atherectomy with the orbital after the imaging, and followed by the mini crest technique for the final left main bifurcation stenting.
And let's pause 1 second here. I know that a lot of talk happened with the IVUS versus OCT. And till we have better agent, which cannot affect or will not affect the renal. So one of the big, the kind of dichotomy, anybody with a high creatinine like this particular patient with a GFR less than 40 will go with IVUS. Even some people say you can do a little injection with a guideliner and then put a OCT through it, and so, but still some contrast will be used. So this case, we decided to use IVUS, and we are going to show you that IVUS picture. The second question basically was, which will be part of the calcific, I think, discussion later on, orbital versus rotational. Many times you can use both of them, but we thought that we have shown quite a bit of rotational atherectomy in all the live cases, even from here, last year and before. So today we'll show the orbital atherectomy. So orbital is actually, so if we can show what orbital is, first we show a little theory, and then we show the actual our setup. So if we can continue our slide presentation. Next. Yeah, so these are the two. We know the rotational and orbital both work slightly different and different wire. The rotational is a cone, and that's where the ablative surface. Orbital, it's not at the tip. It is little proximal and very eccentric. It's eccentrically mounted. They call it a crown.
Crown.
So one is the 0.9 wire, 0.09 inch, and the other one is 0.12. Next. Yeah, and we can play both of them. Play the orbital also on the right side. So these are the two kind of the mechanism. They have to play the
orbital.
Orbital also. So the little bit of individual differences, I think part of them have been discussed already, and they have to just play the orbital also, which we told them outside.
Play the bottom right video, please.
Yeah.
Play bottom right video, please.
Yeah. So basically, while the rotational atherectomy is at the tip, and once it crosses, it has done its job. You can do 10 times, it doesn't make any difference.
Play this video, please.
Yeah. Orbital, the right, the bottom, they have to play.
You have to click it.
Click. I taught them outside. Yeah, good. Can they play or no?
Yeah.
Yeah, now they're doing good.
Yeah,
Because question wise, I wanted to show a little different. So this is the one is the bidirectional and orbital. The name is orbital because it is not only going the horizontal, vertical also, and that is speed dependent. Guys, continue to play that. Okay. Therefore, you have higher the speed, so it will do more turn into the orbit and have a better ablation and or sending they call basically, and the slower speed is less. Only problem is with the higher speed, which is the two higher speeds, 80 and 120,000, and it's the single crown, which is 1.25 compared to rotabur, which has multiple. Here, the speed gives you different lumen, but bigger lumen or 120,000, which might give you lumen of 1.8. But risk is you can cause more dissection and more perforation, but very effective strategy. And so only thing is the wire, little difference. Wire is a 0.012, which is stiffer wire, so tortuous lesions will be trouble. But the particle, there's a little difference in the particle generated. Generated particle with a rotational atherectomy about 5 micron, 5 to 6 micron, and below the RBC is 7.7. But the particle generated by orbital are usually 2 to 5 micron, much smaller. And that is why every study of the rotational orbital atherectomy have shown lower slow flow compared to historical rotational. I mean, there is only one trial head-to-head called DERO trial which compared rotational and orbital. It was more of an imaging study. There was not much difference in slow flow. Even our data, we don't have much difference in slow flow, but traditionally, because of the small particulate generation, it has caused less slow flow, so that less hemodynamic compromise. So somebody who has a low ejection fraction, you'll prefer or selectively prefer orbital versus rotational. Otherwise, majority of the time, you can use same, as I said, tortuosity, more rotational. Osteal lesion, more rotational. And but hypotension, the LV dysfunction, more orbital atherectomy. So with that note, if we can show our orbital, the diamond back, now it has been taken up by the Abbott, and they are the one marketing it, and this is actually the device. If we show the good. So you see that it's a little type, the things just like the rotablation, but all the controller are on the right here in this advancer. So this is the knob, and this is the brake. Compared to the clip and others which are happen, there is no clip compared to rota, and this is the brake release. So basically, once you stop it, yeah. So this is the brake.
Very good.
And this is, and the fluid connection is about the same speed of the fluid infusion. They say slightly faster in the orbital compared to the rotational, the way it is. And these are the two buttons of the, which I would say 80,000 and 120,000 RPM. So with that note, we are ready.
We'll show you the IVS pullback first.
Now let's show the case presentation, which you have taken the pictures now. We say acute pictures now. This is show our first angio.
Go back to angio, please.
Right. Go to the angio now. Before IVS, don't go to IVS yet. Yeah. Now this is our acute. You see that?
This is VL 3.5, 7 French guiding catheter, VL3. And it shows that there was a little wedging. So there is a plaque also involving the osteoproximal part of the left main. And the distally, it's quite tight. And we can see the fluoroscopic visible calcium also, right from the left main to LAD, ostium, and also in the circumflex. And we've taken a pullback. Next, please. This is the first IVS pullback. Next.
Okay, next. we
Show
just-
the IVUS.
And now we can show the IVUS of the circumflex. You know, the circ, there didn't seem to be
IVUS
much.
picture on the main panel.
Yeah, there doesn't to be angiographically much calcium. There is a calcium in the LED and left main, but not in the circ. And you see it there.
Yeah.
This is circumflex pullback. Yeah, vessel looks like 2.75. And
Yeah,
there is a-
calcium at most 90 degrees
Yeah,
here,
yeah,
what I'm
yeah.
showing. The rest of the vessel, not much
yeah,
calcium.
7
Very
to
good.
10 o'clock. And there is a thin sheet of calcium here and there, specks
A
of
bit
calcium.
calcium up here,
It's a fibrocalcific.
up here.
And yeah,
Not much, no spot with more than 90-degree calcium, so that's very little calcium
this is the OM2
throughout.
We are coming to the ostium.
coming to the circumflex.
Little
ostium, close
flush.
to ostium.
Yeah, we
Yeah.
did. Yeah.
Now the vessel becomes massively big here, is over 3.5.
Yeah.
There's a lot of plaque.
Yeah.
Plaque volume, I would
Yeah.
say.
Now it's coming to the left main distal. Here you can see the circumferential calcium close to 360 degree or 270 degree.
Over here, everything becomes black behind the calcium because the calcium was so severe. Now we can see the left main body,
Yeah.
which is a focal vessel, and
Focal.
calcium, not some plaque, not mild plaque.
Now I'll show
a
you the
crescent between 10 and 2.
LED to left main pullback. That will give us the clarity about the calcium in the osteoproximal LED and also distal left main. This is a pullback from the LED. This is 11 to 4 o'clock.
3.5 vessel, calcium, a little bit more
yeah,
calcium,
circular.
but not much.
Yeah. Here it's relatively okay.
Yeah. Maybe up to 180
There's
of
a-
calcium in
You
one
have another
spot.
branch, ductal branch.
And
The specks of calcium. Diameter is almost 4 in the proximal part of the.
Small
LED.
calcium there, no calcium.
okay, it's coming.
You see the plaque over there, fibrocalcific between 9 and 1.
Okay.
Now,
All right, so
here
what's
is-
your
No,
strategy?
no, no,
This is
yeah,
the
yeah.
calcium. This is the calcium.
Yeah. See, full
Full
circular
circumferential, full
calcium.
circular calcium.
That is the distal
Yeah,
left main ostial LEDs, full circular calcium, 360 degrees. So with that
That's
note,
right.
yeah, so we are ready with the put up. We thought with that strategy, and maybe Roxana can make a comment because everywhere else we have heard while we are doing it, that we are planning is we are going to a balloon of the circumflex, just high pressure, and for the LED we are doing the orbital with the 80,000, may decide 120 because the large vessel, and followed by maybe cutting balloon at the angle to have a good, because that circular calcium is a short one, and then decide with the mini crush technique. That's our approach. That's what we have been teaching everyone. While you have a discussion, we are ready to start and so. Good. So push and pull.
Go ahead.
Okay.
All right, so it's orbital down the LED,
Yeah.
left main LED, and high pressure balloon towards the circumflex based on the IBUS finding.
Yeah.
There was not much calcium in the circumflex.
That's
So
right.
what other calcium
see how we do
modification
it.
strategy the panel likes to discuss? Whether you want to go for the IVL in such a case where stenosis is not that critical and you can easily go across with
Yeah.
the balloon. This is one of the possible strategy one can argue. Dr. Dangus, you can you can ask for the opinion of the panelist.
Yeah. All right,
Yeah,
Roxana, let's ask Roxana
any-
about now.
any,
IVL versus atherectomy only.
Yeah.
Give 1,000 of heparin. Okay, we are ready
I-
here.
So there is only-
IVL or not IVL. But
Yeah,
one mention I'm going to make before is that because you said, Dr. Sharma said that they use sometimes the high speed of orbital. In the few cases I've used high speed of orbital, I use it while I'm pulling back. So I feel like I have more control of how this, so it doesn't jump out of the desirable area and cause a dissection perforation. So on the way back, I may use the occasionally the high speed, but not in going forward.
Yeah.
What is
So very good point.
What is it
So
size?
it is a bi-directional, going forward and going back. It takes care
Yeah.
of both. So the 1 millimeter per second advancement as well as pullback.
So
Go
what
ahead.
vessel size do you go at high speed? Not the 3 or below, right?
Yeah, it has to 3.5.
definitely
I would
not,
say
but
3.5.
something like that. Something like this maybe on the way
Yeah.
back.
Yeah.
Any other comment?
So do you start with a 120 speed or
No,
first
80. First 80
and then
has to be 80 first.
First, start with 80, all the way 80. Be very happy with the 80. And if you're going to give an extra mile, maybe do on the way back in the end. As you retract it, you do 120.
So,
Just for
Dr.
safe-
Sharma,
Yeah.
Dr. Sharma, it's Roxana. This is a very, very interesting and very important use of imaging in choosing exactly what you're doing. But I guess one of the big questions is, if you were to be told you can't use orbital atherectomy, what would you be choosing? Would it be rota or shockwave or neither?
No, this is a good case for good case. Why is this going further? Yeah. So no, it's a good case for rotational atherectomy also. Very good case. And now question is, would you use a shock wave alone? I mean, when it's a full circular calcium, I always feel that one cut of the atherectomy followed by multiple cuts, which will the IVL will do. So that way, just because of that. So if this one orbital rotational atherectomy is the lead, kind of dealer's choice at the time to show what the new technique is. So this way, but otherwise this is a beautiful case for rotational atherectomy plus minus IVL. But I think this one case after rota, our kind of trial rota cut, we'll just do a rota, do a cutting balloon. If lumen is good, it expands fine. Why do you need to increase the cost of the IVL, knowing that IVL cost is everything is incremental, both America as well as India. Now, what we are going to do now, as George suggested, we are going to over the 80 further and coming back go 120. Go. Let's say we are going to do a 120 in this case, which is usual, not our type.
Yeah. There's no penalty by stopping and leaving this catheter distally. Unlike rotablator, you have to return every time. You can just go and stay distally, and then let the vessel relax and come back. One more comment.
Dr. Samin, this is Atul Mathur.
Yeah,
So
Atul.
broadly in your routine practice, how do you split your calcified lesions between IVL, rota, and orbital atherectomy?
Yeah, I will show actually our the data once my time will come. But just to say, we do a lot of workshops. So rotational atherectomy, we do about 65 the atherectomies per month. Of the 65, 55 will be the rotational, 8 will be orbital, and 3 will be lesion. And then about 1/3 of the time it will be combined with IVL. So so as you see, we have done this now, and then we break release, and then we are going to take it out. Although there is a glide assist, which you can also do, the taking the device out. Yeah. Good. Pull. Yeah. Slow. Yeah, but so we have big rotational atherectomy. So, and now I can say the future of orbital is dependent on the key trial, which will be presented this month. And of course, if it has shown no benefit, I mean, that's still okay, but as long as it didn't show any harm, so yeah. If it had no harm over balloon angioplasty, then of course the use of this device will be very, very low. Now, region is also, there is a difference of about even in America, about $800 between two, rotablation versus orbital. Rotablation is about 1900, orbital is 2600. Here also there is about a difference of 1 lakh rupees between two devices. And if it did not show any additional advantage, then question will come. Why would you go to beyond just using the rotational atherectomy device, which has been there for so many years?
Run through.
Yeah, let's get run through wire.
That's a good question.
Let's take a
Always
picture.
the differential in the cost makes this question very practical. What's incremental?
But this case, just to say, this is the case. If somebody wants to use just IVL, maybe okay also because the lumen is good. And you can try the IVL like cases which was shown earlier. Some IVL will not crack that calcium. So you may have to do that, whether you do rotablation after IVL, which is, we have done about like 8-10 cases so far in our lab that IVL didn't work, and then we had to use the rotational atherectomy because it did not.
Right. Yeah. Well, remember with IVL also something else, just to highlight the technique differences. As I said, the number one is you can cross and then on the way, and then rest your device distally. And you can start your next run from distal to proximal. The other aspect is that you can stay. Like you saw here, because the main area was in the distal left main. You can be stationary there a little bit. You don't have to move. Be stationary to have your maximal ablation in that area, and also produces this very characteristic sound when you're ablating a calcific plaque. You can maintain you can utilize that in order to stay in that area for more effective ablation. These are just a little minor tricks. Terrific result. Now they're going side by side with a workhorse wire in order to be able to utilize a Viper wire as a body wire, or at some point retrieve it. And then they go always with another wire into the circumflex.
So question is, I always want avoid 3 wires. So now the usual, in this case, I think we had to put a wire in the circ also because there is a tight lesion. So as George mentioned, that it's always good to use as a buddy wire. So it's like a modified single blade, the balloon or scoring technique. So we can have, let's use the 2.7520 balloon for the circ. I think we can remove the Viper wire also now. The 3 wire,
George, just a tip from you. If the orbit is not making headway, how long can we stay in one area and how long?
Until it makes a sound.
Yeah.
There is a sound that makes that you have to stop and give a break. How you utilize that time, up to you. You can keep moving, or you can be stationary, or you can go one way and then come back. I usually don't like to go and come back. I like to go one way, stay there, take a rest, come back, stay there, go back again. So I use a full one way the time.
So it's a 25 second.
That's a feature.
It's a 25 second. So you have to prime in your mind, just like, Rota, we do a 20-second ablations usually. The same thing, it's a 25 second, but 25 second has to involve coming back also. So you have to put kind of timer in the mind that not only you 25 seconds you go forward. Compared to rotablation, you do a packing, so by packing slowly. Here, you can gradual advancement. No packing needed, gradual advancement, 1 millimeter per second, and right. So but 25 seconds, it will make the noise.
Yeah, I have a question here. In larger vessels like left main and ostial LED, rota ablation has to be complemented by IVL or at least a cutting balloon or angiosculp. You think if we use orbital atherectomy, the chances of having these complementary techniques are less?
Yes,
it works better than rota ablation in larger vessels?
No, that is true. So, go up. So that has been said that for the large vessel, if you are trying to do go to 120, if you can, particularly if you can go to 120,000 RPM, it's not a very tortuous vessel, and you go to 120,000 RPM, will give you 1.8 millimeter lumen maximum. So question comes is that do you need to? So to me, I think that both devices are very effective. Particularly orbital actually is more effective than rotational atherectomy because the deep cuts. The original our 40 patients study, which we showed on the OCT, clearly that orbital caused more deep cuts, but at the same time caused a little more perforation. And that has been our experience also.
16, 18,
so
20.
it definitely caused a little more trouble. But Jitendra, the point remains is that even with the 80,000 with the RPM, I have to deal with the same way all the left main, like this case, if I had to do in Mount Sinai, I'll do the same way which I do for rotational atherectomy, that do the orbital 80,000 RPM, and let's open the ostium a little more. Go. You have to open the ostium. Yeah. So key is that go 80,000 and then use a cutting balloon because of the large vessel, and particularly if there is a moderate calcium. Now go up here.
This is what balloon they're using now in the circumflex?
It's a 2.7520 non-compliant.
Non-compliant. Let's go 20 atmospheres at least.
Yeah.
We went now.
Go up there. It's a big vessel.
We go to 22, 24, yes.
Go up.
Again.
Yeah, we didn't see it opening very well here because of the interruption in the connection, but now we can see that it opens up very nicely.
Yeah. Save, please save.
Good.
Now it's going smoothly.
And we have a 3.5 just with the same region that we are still going with the 3.5. Now question is, where do you use the IVL? I would say that if IVL is the price of the cutting balloon, you probably will, every case in my opinion, where using a cutting balloon you can use IVL. The biggest advantage of the IVL is it's going to cut the calcium without causing perforation. And but there is a big difference in the cost. So, but I know that by next year we'll have at least 3 other IVL devices. One of them actually laser energy, and they are starting the trial. Trial name is actually fracture. And will probably start in the January of next year. Uses both ultrasonic and the laser energy device. So the two other devices are in the starting the trials. And by year end, my prediction by year end of 2025, we'll have at least because these are all single arm studies, no randomization needed. Yeah, go up. This is the 3.5.
Gupta,
Yeah.
have a comment, a question. Go ahead.
George and Dr. Samin Sharma, congratulations for doing an excellent case. While you're doing a case, something came up to my mind because this is an excellent demonstration of what you're doing with Orbital or Rota, whatever, and discussion is good. There are a lot of cath labs in India where you don't have these facilities available. In this particular case, it's not a huge calcium, I would say it's a moderate calcium. Would you tell the interventional cardiologist of younger age that they can go ahead without doing any such debulking procedures? And if they fail, then they use it as a provisional, or should we have a completely in mind that, of course, debulking first and then do balloon?
Yeah, I think it's just basically what you believe more.
Eccentric.
Yeah, so go negative. We have to go few millimeter inside for the cutting.
Gone.
Go up. So just to coming back to very good point. So I think this case, because it's a, remember it's not only the circle. It's the thickness. Many things will depend on thickness and the length. So if you take in this particular case, we take the our imaging score. Yeah. The imaging score. So this probably will the score will be because there is a 360-degree calcium. It is less than 5 millimeter and it's the less than 0.5 millimeter in thickness. Remember we say the rule of 5. 5 means 50% arc, 0.5 millimeter thickness, and 5 millimeter in length. So this one, there's one circular calcium, one that was barely 2 millimeter in length. Let's take a picture and we put a stent. The one barely 2 millimeter and very thin calcium. So taking all those together, it will come in the whether OCT or RVS score of 1. So that particular case, in my opinion, if somebody wants to just do even high pressure open balloon or using the IVL alone will be good enough. So we are ready with the stents now. Yeah, give us.
So Dr. Samin, I think we are fully satisfied that you see the rule of 5 and although I think your Dr. Samin Sharma's answer are very accurate. I think he gives most of the time one of the best clarification to the ideas of this.
And simple. And just make it simple.
Thank you. And we see coming back to the live case now, this is a great result with the dilation. And indeed, the most important calcified 360 degrees was in the distal left main right before it bifurcates. So that exact area, you saw right before the balloon had a little bit of a
tough time
spot there that you could really pinpoint that all these devices were really needed, because if after that it wouldn't have given with a regular balloon, no question about that. So we'll go now with a long stent in the circumflex.
Yep, that's what we are doing first.
And the mini crush with the left main lady stent. I suppose what do you use? 33
or 38? 38. Yeah, no, that was the whole question was 33 versus 38. We thought that let's cover completely. There is not much penalty in the circ because there is a good landing zone. Put a wire more, advance the wire more of the circ.
Advanced wire though, the circumflex wire, very good. Yeah, it's a little long, but it's better no penalty, as you say. You don't want to. As I utilize also sometimes a bifurcation, you have to decide where you're going to look. You cannot be looking very closely, millimeter by millimeter, both proximal and distal. Otherwise, you're going to end up missing the most important. So at least you choose a length that is long enough. You don't have to worry about the distal, and then you focus with your proximal positioning much better.
Yep. Now, in this case, one also point we wanted to make a point with 7 French, there was a lot of dampening. So I think we had to bring in the LAD up to the ostium. So our LAD lesion from left main to LAD will bring it up to the ostium of the left main. Keep going.
Yeah, that's fine.
So this is a 4 and it's a 4024. I think we should be able to take care of that.
Okay. Let's see if it delivers. Usually the delivery of those is more problematic than anything else. In my view, the big stents have
for the down.
always a little trouble with a 7 French guide for whatever reason.
I know.
On face value, looks like they fit.
Yeah,
But, in
yesterday-
reality, not so easy to fit.
Yeah.
Um,
And
but,
it breaks. Sometimes because it's bent,
yeah.
hypotube, and it breaks. Actually,
Yeah,
I had a
now here,
case I
over
did
here.
yesterday, break. Okay, good. It's very good. Okay, so we are ready to take
Excellent.
a picture.
All right, so this way, we see that we cover distally very easily, and we're ready to go up essentially with a circumflex balloon.
Ready?
Yeah.
Yeah, we can even go in a little bit if
Sir,
need
no,
be.
Sir has to go in a little more. Advanced
Yeah,
Sir,
go a little bit
4
more.
millimeter.
Yep.
Yeah, in order to make it mini crush. This is a little bit more of a classic crush.
This looks okay.
Good,
We
go
can,
up.
check, we can check it.
No, no chair. Go up.
Go.
Yeah. 10, 12,
All right.
14, 16. Good. Good. Negative.
18.
Save. I will come back a little.
And then you can go a little higher. So this becomes a I would say modified decay crust that your ostium, you have opened it now.
Yeah, to
Little
20
more,
now. Yeah.
20 now.
Save.
Yeah, very good.
Okay, now you have to take both the wire, our bifurcate app has shown that now you have to take both wires. Some people do leave the wire, no, because there will be one day you will cut the wire. So both now you have to take the wire out and so. So clearly now,
Both are.
and then you need to make sure that your LED, your other stent has not moved, proximal or distal, just to say little position wise. And ideally if you have pressed it, then it has not moved. If moving it, it means that you did not come with a side branch up to the ostium. I think we are good.
Okay, go up.
Yeah, go up. Yeah.
Yeah. Save.
Very good.
Okay. Now 2 millimeter back and go 14. We have a good 4 millimeter vessel, and we'll do a 5/4 pot. Yeah, good. Go here.
Go.
Yeah.
Save.
So what I will do, if that's okay, because I know there is a lot of, we are behind with the schedule. If you are okay, if pictures look good, the rest is simple. We are doing a pot and then kiss.
And then do imaging, final imaging.
Yeah, final imaging. Right? You are okay that we come out and you start getting your lectures? What do you think?
Yeah, I think so, particularly since the next lecture is going to be orbital versus rotational atherectomy. Based on the case-based discussion learning. I think that's exactly all the questions that we addressed here. So I think maybe we get ready for this lecture by Dr. Rao afterwards.
All right.
I think it's important to know, Dr. Sharma, if
Yeah.
you're going to do a final small kiss there
Yes. Yep.
in that,
Yes.
can you just let us know that exactly what you're hoping to do? You're going to do a pot and
Pot.
then a kiss?
Yeah.
Or
So
a
question
kiss
is no.
and a pot?
They are the two approach. We always do the kiss and then pot, because otherwise then pot, repot, all those things they talk about. And even with the non-left main, they do cross now. You have the wire.
Yeah, we can give me the wire. At least.
No, hold on
Wire.
one second. Before you go to pot and repot, you can see that the distal, the circumflex needs a little optimization there. So the high pressure balloon needs to go first distally, optimize the circumflex stent, and then do the kiss balloon, and then finish with a pot.
Yeah. No. What we do is we are going to cross now, and then we'll have a 4/0 high pressure, and then 5/0, 4.5 actually, 4.5, right? Left main was 4.5. 1, 2, 3,
Yeah,
4.
left main was
4.5. Yeah. So yes, so we are going to do clearly that first recross the LED, and we go high pressure into the circumflex. I mean recross the circ, and the high pressure
George.
there to open it up. Yeah, good. Yeah.
George.
Good. And then
George?
do a kiss, and then ultimately the pot. Get a 2.7.
George, can I ask a question?
Go
sure.
ahead. Dr. Carr has a question. Dr.
Yes.
Saibal Carr,
Saibal.
expert interventionalist from Los Angeles, California.
From Greece. Okay, so
This one.
Samin, when you were positioning the left LED stent,
Yeah.
did you, like, I always get worried about missing the ostium of the left main. And I usually look at an LAO view.
Look at it,
Because
yeah.
sometimes you, because you wanted to go right up to the ostium, right?
Yeah, yes.
So don't you like to do is just checking ostium left main, LAO cranial to see that you've not missed the ostium of the.
So very good point. So I think what happened is before same that at the time of the imaging we have established that where we are going to see the ostium, and we found that this view, which we are working, we are actually the kind of one view team that we will be able to see even the ostium in this view. So we exactly went there, and that the calcium was the marker for us also.
Yeah,
So now
so
we are going with this because of that. Yes, if there is a doubt, you go to another view also. Yes, that is correct.
Thank you.
Okay, this is a used balloon. So I think we
go on.
decrease the
Too
profile.
ambitious. Too ambitious.
Okay,
To use
that
a
is
used
2.5,
balloon.
2.5 high pressure.
Yeah.
He'll go.
it doesn't-
He'll go.
Yeah.
He'll go. Yeah, open first. Yeah, good. And then we go distal. Yeah,
Same.
good. Now go to distal. There you go 24, 22 atmosphere. That's the one which has not been expanded.
Yeah.
And we have 4O balloon ready?
Yeah.
Yeah. Yeah. Yeah. 4O, 15 is good. Anyone, give us. Yeah.
This is okay. You can
Good.
go here.
We are within there. Yeah. Go here 20.
Can go further in. Yeah.
Yeah.
Any advantage of doing the port first in this case? Like
Yeah. So I think
optimizing the
so,
left main?
If the crossing is difficult, then we can do up.
yeah. Because point is the pot, then they say, well, once you've done the kissing, you have to report again. So because of that, and so pot report, a lot of people love it. We are not that hot. Actually, if you saw our paper in the Jack intervention, the pot technique, where is the evidence? Remember, non-left main, there was a trial called Pot Pro, and there was actually no advantage. Rather, your kissing was a little better than the pot in terms of the stent maloposition and so. So key is that one pot. But yes, clearly the big, when would you do the pot right away first? It will be if you cannot go to the side branch. But yes, people do it all the time. They do a pot.
Is there any small chances of wire crossings by the side of struts in the left main if guiding is not?
No, initially,
Yeah.
when we crossed with the
Yeah.
circumflex,
Yeah.
the guide was very much inside, very much coaxial.
Yeah. But you are right.
Yeah.
So that is one of the people say
Yeah.
that, and therefore technique should be that you put a wire into the LED first and then come back and go to the circ. Yeah, let's go up. Yeah.
Any
Yeah.
question from the panel?
So yeah,
Not
so
yet.
no, that's actually Jitendra asked a very
Okay.
important question about the pot and so
Okay, question from the audience. Go ahead.
Deeper.
In one third of the cases, sir is saying, Dr. Samin is saying that we use hybrid IVAL and with orbital and so after
Both
every
together.
this orbital atherectomy or rotational atherectomy, do IVAS at every stage
14.
practically, or you see with the fluoro only and
Same.
then decide to go for the second the hybrid procedure?
Very
One.
good.
And number two, the second is
Both of them to the
that
osteum.
is NC balloon after orbital or after rotational atherectomy, or the cutting balloon is required in every case, or you decide on IVAS or on fluoroscopy markers only?
Yeah, so very good point. So I would say the degree of calcium decide whether you do use a cutting balloon or you do high pressure. Secondly, that this distinction, should you do it every time with the IVAS, the real good, those who are, I would say the IVAS imagers or intravascular imagers will do that way, but we don't. We'll just go by the angiogram.
Little back.
We definitely will do the imaging in the end. So not multiple levels unless it's part
Boost
of it.
again.
Like we did the Rotacut trial with the Roxana was all the protocols were written. There we did IVAS like multiple times, but otherwise you just decide based on the angiogram. And particularly if you are doing the OCT, then it's a multiple OCT, multiple dye runs is the issue. But I think looking at it now, question is, if it's just a mild calcium, you want to go high pressure after the atherectomy or orbital, I think that, or rotational, that's good enough. You don't need anything further.
Yeah.
But yes, if it's a heavy calcium, then it's better to use a cutting balloon plus minus IVL.
Right. I think
Dr.
already.
Sharma, I'm
Yeah.
also noticing that you're not using any kind of a support, In the US, a case like this, usually people look for some support with so much complex work in the left main and bifurcation. if you did this, if it was, would you do this with Impella or not?
Yeah. So this case is a little different because LV is completely normal. So this is the kind of case I would say if the RCA is open like in this particular, go both of them. If RCA is open like this case, I think you can just go away with the balloon and so, balloon pump.
Yeah.
But definitely not the Impella case. But if RCA is total, even with the normal ejection fraction, then it's the ideal case for the Impella.
Yeah, but I'm noticing that this patient is tolerating, I
Yeah,
mean,
yeah.
even with this difficult. So I'm often wondering, are we overusing the protected PCI? And we discuss this all the time, you and I, Dr. Sharma.
Yeah.
But when you're in the operating table, I never worry. But it's important to better understand what else is, what other people should be doing and how we could save, resources. But this was beautiful case, beautifully
Let's
done.
take a question from the audience.
No, Samin and Dr. Roxana, I think I completely agree. When your concern was hemodynamic collapse during any of the complications if we have during this. Dr. Samin Sharma is having huge expertise. But for young people, I think it's better to have intra-aortic balloon pump, even if their LV is normal, so that if at all there is some complication, you can at least have something to support. Not Impella, of course. Impella, when you have very bad LV, then of course. But in this case, intra-aortic balloon pump should be used by all the people, unless you are hugely expert like
Unless
Dr.
Dr.
Samin.
Sharma is your intra-aortic balloon pump
So
and
I
your
completely agree with Dr.
Impella
Roxana.
Max devices.
It's a really, really good point which she has picked up, and it's very important for the young people anywhere in India, especially, or all over the world, I would personally say.
Yeah,
great.
LV function is 50%. Ejection fraction is good. And although in India, we have come up with the Indian algorithm for use of MCS. And that is one of the talk which I'll be doing in the afternoon. We made up a score based on clinical and technical characteristics and then decide how to use it. Score 3, less than 3, use conservative approach, 3 to 5 may consider, and more than 5 you have to go for the LV support.
One more question.
Yeah, EBC recommends a non-distal cross in the crush for the side branch rewiring. So how important is it to cross the non-distal strut in crush?
I don't think anybody can control that, but it's always good to say that.
I was live now, guys.
Pull back.
I was pulled back from the circ. So question is, I think that has been overrated in my opinion. Overrated. If you go to the middle, you're good enough.
Yeah.
You go to the middle of the strut, the good enough. Don't waste too much time. What you'll do, you'll cause more deformation, back and forth your guide. And remember, in the October trial showed 16%.
Landing zone is good.
Yeah. And you see
That was just a beautiful transition of the distal vessel into the distal edge of that stent, beautifully implanted. No issue at all in the distal edge. I just want to say, as I'm looking at this IVUS.
And a little bit of fibrotic plaque in a 4 to 9 o'clock position, but luminal gain looks quite good. If required, we can go with the NC balloon, a small 2.5 into 10 high pressure.
So far, very
2.75. We did 2.5.
Yeah, 2.75, yes.
Yeah, 2.75. Now we are coming to the proximal circ.
It's middle of the
Most
OM.
important is to see what's going on in that bifurcation site, that it's well opposed there, which looks really good.
Fluoro, where are we? This the
Yeah,
one?
yeah, yeah.
Oh, fluoro
We're
is
still in
going,
the OM, yeah.
We are still in the OM.
Sanjeev, we are 1 hour late, so
No,
I think we can.
you can move. There's just IVUS pull back, just circumflex.
And then we are done.
Yeah.
We are not going to show
This is
anything
a
more.
really important teaching point. You're right, but I think this is if we're going to use imaging, we talk so much about it in bifurcation lesions, we should know what we're looking at. And I think to me,
Now
this
it's the
is the
left
most
main.
crucial part.
Yeah, left main, figure of 8, and
It's
looks
good.
quite well opened up distal area, distal left main, which was very critical to begin with. There was a calcium 360 degree arc in the distal left main. Now it's nicely opposed. So we need to go with the 4.5 millimeter balloon. Looks expanded fairly well, or at the
Good.
osteoproximal.
And see that we are one strut outside. So we are good. We cover the ostium. All right, with that note, we stop here.
Let's take a final angio. Take a final
Okay,
angio.
show the final angio.
Go and we go.
Yeah, good. Show the final angio.
Yeah, take it off.
I feel like you're projecting from Mount Sinai, but it's really it's really right here.
It is the same thing. It will the same thing.
Amazing, amazing.
Yeah.
That's terrific result.
All right. Thank you.
Yeah.
That's a terrific result.
Lucky
And,
patient.